So yeah, this is the continuation from last time, what I presented. So basically, I tried to talk a little bit about neurobiology of sleep and addiction problem and how they are kind of interconnected with each other. And this is Dr. Norovoko's article and publication a couple of years ago, I think. So this is the this article talked about 5 different pathways, sleep pathways, which is kind of very important. They kind of definitely interact with each other, so affect our sleep-wake cycle, and it's very important to know them, especially in the addiction population. So then the second part I will talk about basically what we have learned, what our small prospective study. It is a pilot study conducted some years ago by Dr. Sullivan, and also we have some residents involved. So we had a publication, and so I just give you a report on what our findings in this presentation. So to continue from last time, so we talked about different pathways in sleep. We talked about locus coeruleus, which is kind of norepinephrine system, and that's the system kind of got overactivated especially during opioid withdrawal. That's why that's where the clonidine and norfexidine, this type of medications, are kind of can target. We also talk about a histamine system and also serotonin system. So all this kind of pathways are kind of very, very important. It's kind of interesting. We all know, like, dopamine pathways. For the dopamine pathways, our brain has basically 4 different dopamine pathways. And we know dopamine pathways are very, very important in our reward circuitry, right? That's the main, main neurotransmitter in our rewarding, behavior. So, but it is a lot of studies were done in dopamine pathway, talking about trying to investigate the relationship with dopamine pathways of mesolimbic pathway, especially mesolimbic pathway and mesocortical pathway. These 2 pathways, how, what kind of roles this pathway can play in sleep, and not much was found. So basically, it was considered not really sleep related. However, we all know, it's interesting. We all know people, when they abuse drugs, especially stimulants, we know their sleep definitely, sleep pattern changed, and sleep cycle and disrupted. And also a lot of people try to self-medicate to keep them awake. So this pathway is kind of related, we know. But then the key is here. So the orexin system, which is the main sleep pathway that interconnects, actually orchestrates, and also coordinates, synchronizes all other 4 pathways. And also we know this pathway is kind of has very close connection with mesolimbic pathway, rewarding circuitry. So that's why, and so people kind of abuse drugs, even if the dopamine pathway is not directly involved, but because of the orexin pathway. So we know actually dopamine pathway is kind of related to sleep cycle. So next slide, please. So just one slide to explain the orexin. So 2 slides actually. So the first slide is, we know that orexin, this neurotransmitter, okay, or hypocretin, those cells fire during waking, and they're more silent during when people are in sleep. So that's kind of interesting. And we know the upregulation of orexin would be expected to create a state of a hyperarousal, and may underlie the insomnia observed both in treated and non-treated opioid users. So in other words, orexin and the change of orexin level is very much related to our sleep, to the sleep disturbance in these patients who abuse opioids. The next slide, please. So some scientific findings from labs. So the first is clinically, people suffering from narcolepsy, so which is kind of sudden attacks of sleep. People kind of have excessive sleepiness. They kind of sleep all the time. It's hard to maintain, awakeness. It's hard to stay awake in those people. And we know this is narcolepsy people. They can have sudden drop of cataplexy, which is kind of paralysis of the body. So those people, they have very low orexin level. And they found the potential to abuse opioids kind of low in this kind of population. Now, we don't know why, but also their studies from UCLA, they found like even for people with narcolepsy problem and giving them opioids such as codeine, they might help them to stay awake. So it's this kind of, it's of course it's a study, and it does not really, it has no real clinical relevance now, but it's something that's kind of worth investigating. So also lab mice with genetic deletion of orexin. So orexin, they said about like 800,000 orexin cells in our brain normally. But for those mice, if we delete the gene for orexin production, and they do not have enough orexin, then those mice tend to less likely to get addicted to opioids. And also chronic opioid exposure can upregulate orexin in humans and rodents. That's just that's a finding. So postpartum brains of heroin users showed increases in orexin neuron numbers. Is that because it's upregulation? In the previous slide we mentioned that. So is that directly related to the rewarding behavior? So we don't know. Also, orexin microinjection into the VTA, ventral tegmental area of the midbrain, so increases cocaine self-administration and reinstates cocaine conditioned place preference. So it's kind of, it's kind of, still it's under investigation now. So a lot of studies need to be done to find the role of orexin in addiction and sleep. However, so the question is, we know orexin, if you do not have enough orexin, then the chance of abuse opioid could be lower than if we use orexin antagonists, such as orexin cannot be a potential medicine in the future for opioid use disorder patients. Now, we don't know, but this is just a question and raised in that article. Okay, next, please. So, okay, so I kind of summarized what I learned from Norovocal's review. Actually, it's a review article. So now I want to talk about this small pilot study we did in our code population. Okay, next. So this is the publication, self-reported sleep improvement in buprenorphine MAT population. Next, yeah. So the background is, basically, patients with opioid use disorder can have a lot of sleep disturbance. Now, we know that. And also, mood-wise, they can be very depressed. And we don't know which one causes which. And it's very complicated. We know sleep disturbance and drug addiction could be very much interconnected, neurobiologically. However, which one is the cause? Or which one should we target first? Or should we just treat both? And how should we target? How should we treat clinically? Because even like, I remember when Dr. Barry was running DDU, and basically he discouraged people to discourage the treatment team to talk about sleep. Because if you ask patients sleep problem, and of course, then 100% people will have complaints. Then the whole group discussion would be kind of, in a totally different direction. So would that be therapeutic or not? Now, we don't know. So, but we know that all our patients have sleep disturbance. They have sleep complaints during acute intoxication or withdrawal, or chronic use, or we're talking about even in maintenance phase. So in beginning group, intermediate group, or advanced group, they still could possibly have a lot of sleep problems. So let's find out what's going on in this population and what are their complaints about their sleep. So next. So the first, the background. So of course, for any study, you want to find out what other people have studied in the same population or similar population, and what are previous findings. So to summarize, just one sentence, very inconclusive, very inconsistent. We don't know. So generally speaking, and chronic substance use can disrupt circadian rhythm. Now we know that. And also, opioid use is associated with increased nocturnal wake times. Now we know that. We know people can have fragmented sleep. They always wake up, multiple times throughout the night during active drug use. And that is a clinical phenomenon, and everybody knows. So then Marasco in 2014, and in that article actually talked about dose-related sleep problem. So it's related to opioid dose or opioid medication dose or the drug doses. So also there are a lot of evidences supporting drug addiction is highly associated with sleep apnea or sleep disorder, the breathing problem. So that's especially central sleep apnea. So the question is, well, our treatment, opioids, which is a partial agonist, Suboxone, buprenorphine, help or help with sleep or make sleep worse. Now we don't know. The previous study is also kind of inconsistent. Next slide, please. Mm-hmm. So generally speaking, substance use can have problem with can cause problems in sleep. Of course, methadone as one of the FDA approved maintenance medications for opioid use disorder definitely can also play a role in the sleep problem in this population. So again, so methadone can cause sleep problem. Methadone can cause central, we're talking about sleep apnea, can disrupt the sleep circadian rhythm, and can affect sleep latency, can cause all different kind of problems. So the previous studies, they did, different studies use different ways to investigate. What I'm trying to mention here is like, those studies are pretty good. They use the sleep study. We're talking about real sleep study. So that's more objective way to study the sleep disturbance, right, for patients. Also there's studies like us just to self-report. So the Pittsburgh Sleep Quality Index, PSQI, is a kind of pretty commonly used research sleep scale. So so that study from this SUD in 2012, they analyzed the correlation between related factors such as duration of opioid exposure. We're talking about how long you have been exposed to methadone, and the dose, and also the severity of the sleep problem. Then they use the PSQI to measure the outcome, the sleep outcome. Of course, they found that definitely those people on methadone, 70% of them are poor sleepers. So they're not sleeping well. However, the question is, when those people were actively using drugs, then what percentage of people were bad sleepers or poor sleepers? So we don't know. And this article did not mention about it's kind of descriptive. They described the percentage, but did not really have a very good control because it's very hard to do this kind of study. Next. Mm-hmm. So buprenorphine and sleep. Again, buprenorphine and sleep, many studies were done, but no conclusive results. So we don't know. So finally, in 2012, did a cross-sectional observational study, and they found buprenorphine naloxone might induce significant central sleep apnea and hypoxemia, which I understand because it is an opioid. So one in 2015 did a case report. They reported the successful reversal of central sleep apnea with change from methadone to buprenorphine naloxone. So in other words, the final study said buprenorphine naloxone use can induce central sleep apnea and hypoxemia. But one case report actually, report the opposite. So using a change from methadone to Suboxone can reverse the central sleep apnea. But that's just a case report, not really that strong evidence. But Lucas in 1996 also studied buprenorphine treatment in heroin-dependent men and suggested it could improve sleep disturbance and normalize sleep patterns. So his result was kind of positive. Buprenorphine may be a good thing, to help people with with their sleep during their maintenance phase. Next. So again, tapering. So if we do fast taper and a slow taper, then of course those people who are kind of tapered slowly, of course there's no consensus on how long we should taper people off Suboxone, buprenorphine. Doesn't matter whether it's in what kind of setting. So, but at least this study in 2015 suggested slower taper may basically patients have less disruptions, fewer disruptions in sleep than comparing with those people who are tapered very fast. Otherwise, we're talking about buprenorphine can improve sleep quality in another study from same group almost, and Yalas as well, recommended that. So, but different kind of mechanisms, which is kind of very hard to explain. Okay, next. So, anyways, so we want to do some studies on our own population. So we know code model is kind of working, right? We have good retention rate, long-term wise, and we have a lot of patients kind of showing very good satisfaction to our treatment. We are a comprehensive treatment program. Actually, I'm writing a manuscript on our pain population, chronic pain population, with addiction problem, and on high-risk clinic. And actually, this model works because our retention rate over there is pretty long. Okay, very good. So the question is, in this population, how well do our patients sleep, and what kind of role does the buprenorphine or Suboxone play in the improvement or worsening sleep problem? So the primary outcome of this study was trying to find out the effect of the buprenorphine basically on patients who using MAT, right, in the code clinic. We hypothesized the patients would report poor sleep at entry into treatment and show some improvement in sleep over time. So we want to follow up. So when they enter the program, so we ask them questions about their sleep. We ask them the questions about their their perception of the relationship between the treatment and the sleep problem. Then we just follow up at different time points. Okay. The secondary outcome is we also at the same time we kind of try to we ask we evaluate the sleep. We also try to find out whether their mood, the depression can get better. Now we know a lot of people are depressed, right? During active use. So same thing. So we want to find out whether buprenorphine treatment, or actually I shouldn't say buprenorphine treatment because this is there's so many confounding factors, and also we have a very strong psychosocial intervention component. So basically we're trying to find out whether this code model, code program can help patients with their mood. Okay, so our hypothesis is patient would report some improvement in depression as measured by back depression inventory with time going on across time, treatment time. Okay, next. So the participants is code clinic patients with opioid dependence disorder, or opioid use disorder now, actually DSM-5. The study was done in DSM-4 time. The only exclusion criteria was active pregnancy. We did not include pregnant ladies, even if we have a big population of pregnant ladies, but we did not really use them for this study. The reason is kind of it's very it's a lot. Pregnancy itself can play a role in sleep. So informed consent was obtained, of course, prior to participation. Like every other study. Remember here, if you want to do a research, you need to get an IRB. You need to do you need to get a CD training for human subject research. All these kind of basic things. Subjects received no compensation. We did not pay them for this study. It's just a survey, and it's purely voluntary. And no change in concurrent treatment. So that's another thing. So I got a lot of questions from reviewers during the submission process, because what happens is basically they ask you, they said, well, you have a lot of confounders, because some patients are taking trazodone, some patients are taking Benadryl, some patients are taking, but we know patients are not taking any benzo because that's disallowed. So anybody in our in this study, they're not supposed to, or they at least we know they're definitely not on prescribed benzo or any controlled substance. We know that. However, yes, they're allowed to take their antipsychotics. Yes, Seroquel is allowed. So we try to kind of mimic the real life situation, and this is a real world practice. So we want to find out what's going on, whether buprenorphine can, the co-model can help. So it is approved by WVIRB. Next. So the measurement of outcomes. So we want to measure the sleep. We want to measure their sleep. We want to measure their mood. So we use medical outcome study Sleepscale. I'll talk a little bit more in the next few slides. Then we also designed a supplementary sleep scale with a few questions asking whether they're actually, their opinion on the relationship between buprenorphine medicine itself and the sleep change. Now, of course, we use back depression inventory, which is kind of a very standard rating scale for any research studies on depression. Yes, next. So this sleep scale from the medical outcome study is it's a 12 questions, 12 item scale. It's complicated. It is, we did not use Pittsburgh one. I don't know why, because Dr. Solomon designed this. But anyways, so this scale is kind of, the problem is this is a good scale. It's validated, okay? It has been used in many research studies on sleep. So the problem with this scale is some scales, if I show you the next few slides, it's very hard for you to score, to summarize, to get a comprehensive score. Because some questions, higher scores means good. Some questions, high scores means bad. But there's a scoring algorithm we can use. So that created a lot of work. But anyways, it's easy to use. The good things like those questions are kind of straightforward. They basically ask patients about their sleep in the past 4 weeks. Pittsburgh's sleep scale, same thing. It's also asking questions about past month sleep. So it's past 4 weeks, pretty much same. So the first question is how long did it take for you to fall asleep? But basically we're talking about sleep latency, and whether, so of course the lower score is better. Next. The next question is just a number. So how many hours per night on average you sleep in the past 4 weeks? Next. So next few items is basically asking about did you rest well, and did you snore, and how good was your breathing during sleep? All this kind of questions. Next, yeah. So basically all these kind of questions. So 1 is all of the time. Then 6 is almost none of the time. So then you can see some for some questions your answer like all of the time is good. For some questions, like you feel restful, you feel rested in the morning. But for some questions, like all the time is bad. Like you have trouble falling asleep. You snore all the time. All these kind of things. Next, yeah. So this is the algorithm to score the quality of sleep and whatever. But what I'm trying to go to next. So some questions you have to reverse, then you have to combine them. So here are the subscales. So basically, this evaluation, these 12 questions can help us understand the patient's sleep disturbance, how bad it is, snoring, okay, whether the patient snores a lot or not, then shortness of breath, okay, or headaches during sleep, sleep adequacy, sleep somnolence. So then the two combined indexes, index 1, index 2, is overall sleep quality. Okay, so next. So then we also had another 5-item supplemental sleep scale to ask information about patients' overall perception of Suboxone treatment. So overall sleep quality, sleep improvement, and relationship between sleep change and buprenorphine use. So we have a specific question asked: what do you think about the relationship between your sleep, the buprenorphine and your sleep change? Now also we have a question asking about additional substance use in the past 30 days, whether they relapsed or not. Okay, and how many times they have relapsed. Next. Mm-hmm. This is just a question. I'm not going to repeat this. So next. So a back depression inventory, it's just commonly used a self-report instrument for depression evaluation. Okay, it has 21 items. So basically 4-point scale for each question. So, but the bottom line is if the patient's score is lower, then that means almost no depression. So patient can have no, mild, moderate, severe depression, depends on how bad the score is. The higher score means worse depression. Next. So this is the back depression inventory. Basically, it's just asking, like many other mood inventories, mood instruments. So basically ask about their mood, ask about their interesting activities, ask about their concentration, and also ask about their kind of overall, like sleep or those kind of things, which kind of related, kind of also, part of the depression. Next. So we use the back inventory 2, which is kind of, revised version, newer version, but still same 21 questions. So in summary, the cutoffs is kind of a little bit different, but overall, so 0 to 13, if that person scores less than 13, less or equal to 13 is a minimal depression. So 14 to 19, mild depression, 20 to 28, moderate depression, 29 above is severe depression. So what we want to see is a lot of patients may report moderate depression. So their scores should fall between 20 to, we're talking about 20 to 30-ish. So with time going on longer into treatment, cold treatment, by the time they get to the, we're talking about intermediate group. So we would like to see minimal depression or mild depression. So we would like to see kind of score drop, okay? In this back depression inventory. Next. So data analysis, the endpoint, of course, the primary endpoint is also the sleep scores from medical outcome, sleep scale, and also from our supplementary 5 questions. Then the primary analysis, we want to find the score change over time, with time going on at different time points. 30 days, 0, entry point into the program, and also 30 days, 60 days, and 90 days. Then secondary analysis is the depression movement. Of course, we look at the BDI scores, right? Okay, next. So this is our demographic information. This is pretty representative. Even if we only use the, we use the groups here in Morgantown. Actually, it's mainly Dr. Solomon's group, but actually it's pretty much representative. Okay, so we have majority white, and half male and female, and a lot of people are kind of employed. That's good. They have job, and our mean dose, average dose, majority we're talking about is like 12 milligram, dosing. Next. This is the main finding. So remember, I had a table in the previous slide mentioning about the subscores. So the first score is SLP, sleep disturbance 4. So it basically combines the question, combines scores from 4 items, but it's talking about the overall sleep disturbance. So this is, they're colored, okay? This colored bars with day 0, day 30, day 60, and day 90. So you can see the trend, the change. The scores, the sleep disturbance kind of changed, dropped from higher score to lower score. And with a star over there, it means statistically significant. Okay, p-value is very, very low, less than 0.05. So for snoring, there's no statistical significance. Okay, we're talking about shortness of breath, sleep adequacy, and somnolence. Not really. We didn't see any. We saw some changes, but we did not see any significance. Okay, but for 2 sleep indexes, SLP6 and SLP9, basically it combines answers from 6 questions and 9 questions, different questions to reflect the overall sleep quality. Actually, you can see the score drop, score decrease over there, and with time going on, right? So that, and also they are statistically significant. Next. So this is a fixed regression model. So it's kind of, fitted models. They use that. This is a fitted line, but they use the mixed effect regression model. So what it means basically, it takes consideration of different kind of confounding factors, gender, whether males and females are kind of different, age, whether the patient's age kind of plays a role in this score change, and also we took consideration of buprenorphine dose, and none of them played any statistically significant role in those changes. So you can see clear decreasing trend in all these 3 scores. Next. That means just with time going on, the sleep disturbance is less and the sleep quality has improved. This is a sleep disturbance. So basically, I just summarize the mean score and the p-value over there. Next. Mm-hmm. Yeah. Mm-hmm. So this is the mixed effect model. So we're talking about over time. You can see, yeah, actually I circled them. Yeah. Next. So those are the changes. So that means they're kind of significant. The p-value is pretty low. Okay, next. So then for the back depression inventory, we're talking about BDI scores. So the depression. So just see the mean score here. Remember, less than 13 is minimal depression. From 13 to, I think it's 13 to 19 or 20 something is mild depression. Then from 20 to 30ish is moderate depression. So this is what we expected. This is exactly what we expected, and this is exactly what we want to see. At the baseline, when patients enter the code clinic, the mean score is 24, 25. That means they have moderate depression. Overall population, not everybody, but overall, the big picture. But with time going on, you see the score change. So after 30 days, dropped to 17, and it's pretty much stayed at 17 in the first group. Now we should have extended this study to intermediate group, or even like advanced group. We may get more results, but unfortunately we didn't do that. So I just want to mention here, this table means a lot to us, because we know, of course we know Suboxone may not work for depression, we understand it. However, given our strong psychosocial intervention, a wonderful therapist team, a wonderful case management team, so I think they played a big role. This was heavily discussed in my discussion part. So I just want to mention that this cannot be ignored. This is very, very important. So if you want to get better, Code Clinical works, because it not only helps you with your sleep, this program, and your mood can get better, right? Overall, that is outcome. That is an outcome. Yeah. Next. Mm-hmm. Now p-value is pretty small. And we see all these p-values. So here's the summary of our supplemental sleep scale result, okay? So remember we had all these 5 questions. So we asked them, of course, we asked them additional substance use, how many times, how many days? We asked how many days in the past you struggled with active drug use. So now so here's the percentage. You can see additional substances, no, almost half of them did not have any additional substance use, and half of them had relapsed, right? Then perceive the relationship between buprenorphine and sleep change. This is very interesting. So one is not at all. My buprenorphine prescription has nothing to do with my sleep change. And 2 is a little related. 3 is somewhat related. And 4 is a good bit related. And 5 is most related. And 6 is very much completely related. It's just because of buprenorphine mainly. So you can see at least we have a good percentage of people reported this kind of, from their perception, okay, they perceive a big relationship between the buprenorphine use, Suboxone, and their sleep change, right? But remember, overall, we had 3 out of 7 talking about subscales showed significant improvement. So I would say it's a pilot study. It's a small population, not many participants, but a lot of patients thought the medication played a big role in their sleep improvement. Next. So this is our conclusion. Then we know Suboxone, buprenorphine, naloxone maintained opioid use patients in recovery. They report definitely in this pilot study, small group, they reported improvement with time going on, longitudinally, longer interior recovery. In this weekly group, they reported better and better sleep, also better mood. However, we have to mention it. Any study, a study is a study, and we're talking about clinically. How can we apply that to generalize that to everybody else? It's very hard to say, and it's more preliminary, naturalistic. This is a real world design. A study of this kind is insufficient to draw any conclusion about the direct effect of Suboxone on sleep and mood in this population. By the way, we're not talking about just Suboxone. When the paper is written that way, but actually we were talking about the code model, because we did explain very well the clinical setting and the heavy psychosocial component of the treatment. So we also, in our discussion, we also mentioned that. After all, everybody knows, and the psychosocial component is so important in our sleep, right? And in our moods. So, but anyways, our study did replicate some previous findings of sleep disturbance in the initial phase of treatment and maintenance, especially maintenance phase, right, when people on MAT. But also some studies, reported Suboxone could help patient sleep and also mood. And I think our study is kind of consistent with those studies. Yes. So yeah, give acknowledgement to Dr. Sullivan and also different people involved in this study, and I want to I take this opportunity to appreciate everybody's work and hard work, and also I want again, because I'm writing this pen, actually I'm submitting the revised manuscript today. I cannot re-emphasize the importance. This is also commented by all my 3 reviewers of the current manuscript. Another one, I cannot re-emphasize the importance of psychosocial intervention in this code program, and everybody agrees that this kind of comprehensive model works, not just the Suboxone. Thank you very much. Since we still have some time, I would like to answer questions.
Thank you so much, Dr. Zhang. That was really wonderful. And the work that you all do is super incredible. So we truly appreciate it. Any questions or comments from anyone? Unmute or chat in. We got a chat in saying from Katie, you're always so supportive of therapy, Dr. Zhang. Thank you, and great presentation. It's a quiet group today. It is a Monday, but.
I was just, you mentioned Balsamra, the suvorexant. Is
Yes.
that on the no-go list for COAT? I think it is.
Well, I think it's a controlled substance. So here's
is.
the thing, Dr. Houston, I always, I always want to relook at the, our list. So the question is, we know those controlled substance, patients using them can, there's a reason why the medicine is listed as a controlled substance, is on that list. So the question is, those medications really, pharmacologically, they work on different receptors, like Lyrica, like Neurontin, but we know the drug-drug interaction concern as well, all these kind of things. So I guess there's no direct answer to this. There's no correct answer to this. But we, as a prescriber, I mean, I never used this suvorexant, this medicine myself. I did check the board of pharmacy. I found some of our co-patients on this medicine. My quick patients on this medicine, I did not continue them because it's controlled substance. I have worries. I personally do not have enough knowledge about this. That's why I studied this Neurovocals article. So we don't know. Seriously, we really don't know. So we really don't know how. How this medication can help patients. So we don't know. I'm struggling with a patient on CRIC now. She's on 150 milligram of Lyrica twice a day, but she's also on high dose of methadone, more than 100 milligram a day. So the question is, what are we going to do? And the patient has been getting Lyrica from other places. And how much do we know about Lyrica and methadone? I mean, the interaction. How much do we know whether this medicine is helpful or is harmful? We really don't know. There's a clear evidence on Neurontin and buprenorphine, and Neurontin, gabapentin, and methadone. We understand that. But for other medications, we really don't know.
So I think with Balsamra, it just got scheduled for because it is a sedative, but I don't know how inherently addictive it is.
I agree. It works on it works on orexin, so it's totally different kind of receptor. By the way, yes, that's kind of important. I think orexin is kind of it's a heavily studied neurotransmitter and rewarding now. So I think it's people are spending time on this. So hopefully, with time going on, we will know more about it. Yeah.
It's also really, really expensive if anybody ever tries to prescribe it for someone, and it's nearly impossible. I still have flashbacks of doing it as an intern, so it's like $1,000, and I think it makes you sleep like 15 more minutes a night. So I don't know if that's quite worth it, bang for your buck.
Jennifer, was there a comment too?
Yeah, Dr. Zhang, that was really interesting, both presentations, and I think one thing that I might take away, and just tell me if I'm getting this right, I don't find myself with my patients chasing too much their complaints about sleep with medication. I mean, if they complain in the beginning, sometimes I'll try, to get a low dose of Remeron or and ask about depression, but I don't find myself chasing it too much. It sounds like, at least from that COAT study, it's it's reasonable to just encourage them to stay with their recovery in the model of the program, and not get too drawn into a big focus on sleep if they're not bringing, if it doesn't sound horrendous, I guess would be my summary. Does that sound right?
Yeah, here's the thing I think is kind of so important. This is because I'm running a CRIC unit psychiatric ICU now. So basically, a lot of people, I mean, this is kind of relevant here. That's why I want to discuss a little bit and share my experience. So I see a lot of patients that kind of meth-induced psychosis, okay? And also I have real psychotic patients, and we're talking about schizophrenia and very disorganized, psychotic, talking nonsense, very agitated, and even aggressive, violent. So how can antipsychotics work? So statistically, the first few days, the first couple of weeks, what antipsychotics actually do to patients is just help them with their sleep, help them with their agitation, help them with the aggression and moods, and also basically help them calm down. And they continue to be delusional. They continue to be disorganized. I have a typical example upstairs now. A person used methamphetamine, got so psychotic, but has baseline schizophrenia, and did not want to talk to us, kicked us out of the room all the time. I had to heavily medicate him because he was so aggressive, yelling, screaming all the time. After 3-5 days, calm, polite, cooperative, of course wants to leave, but totally compliant, 100%. But in the meantime, disorganized, talking nonsense. So my question is, I guess my big question is, we are desperate a lot of times to keep patients in treatment. I mean, especially for meth problem, people with methamphetamine problem. So Suboxone is a good medicine that can tie people to treatment, and we provide a lot of, again, the psychosocial intervention to help patients. So helping patients sleep is important. If somebody has sleep disturbance during early stage of recovery, and in our clinic, compliant with everything. So my question is, using benign medications such as trazodone, such as Benadryl, such as Vistriol, and even like amitriptyline, we're talking about this kind of medications, kind of low dose. They're safe to use, and they could be very, very important. It can increase compliance and can help them. Talking about definitely, better their life, not to say that, but can build up rapport and help to retain patients in treatment. So personally, I think we do need to pay attention to patient sleep. Yes.
Okay, good. That's helpful.
Thank you, everyone. Dr. Morrison, I saw you unmuted. Was there a comment you wanted to make too? We could hear you through that one too.
Okay. I was wanting to talk about the antipsychotic usage from the Coates Clinic relating to sleep, because you mentioned that you heavily medicated someone and got compliance. Of course, I was inpatient. I've got some people who come in very psychotic from methamphetamine, and I have really been conflicted about the Seroquel or other, and I'm not sure there's a difference between Seroquel and other atypical antipsychotics for the usage here. And so I have, I was wondering if the Coates Clinic is often doing that, like the way they would with trazodone.
No. Dr. Morrison, thank you very much for bringing it up. So here's the thing. We try to avoid it's always good to have integrated care, especially for your population. This is wonderful. Your primary care doc, you can provide a lot of things to help patients overall as a person. But here's the thing, we are here, this is our group practice model here. So for the code, the reason we do not want to give them, we always want them to schedule another appointment with a psychiatrist or somebody else. So the reason is we do not really have enough time to evaluate, to follow up the treatment progress. So it's easy for us to provide a medicine, including Seroquel. Of course, using Seroquel for sleep, which is not really recommended. I know a lot of community hospitals, because I covered a lot of community hospitals in the past. I know that it's commonly used. It's effective, but it's not really recommended because of the side effects and everything else. And we have, different kind of other substitutes anyways. So, but the point is, we do not have time to to evaluate patients and follow up and provide better comprehensive care. So we always recommend them to see a separate psychiatrist for psychiatric problem. And if they have sleep problem, well, you know, here's the thing. But as a primary care doc, I know you over there, your facility is different because we're talking about resources, everything, and also your primary care doc. So I would prefer to have somebody like you to help patients with sleep as well. But overall, for psychotic symptoms, I would prefer, to have more close evaluation and a more different level of care. That's what I think. Because we do not want to use antipsychotics to help patients with psychosis unless it's really, really necessary. It's the person we're talking about, because we don't want somebody to use dopaminergic drugs, but in the meantime they can use antipsychotics to counteract. But we don't want them to. By the way, psychosis is a pretty serious psychiatric condition that needs with crisis intervention. So it depends, of course, on what how bad it is. So my opinion, if you ask me, it depends on how bad it is. If you feel the patient is pretty psychotic, and refer that person to emergency room.
If it's not extremely psychotic, which I think you're getting at, like some people with residual kind of meth stuff, Seroquel is usually not a go-to. People like Seroquel. They are used to abusing it. It's used in prisons traditionally a lot. You're better off using something like Zyprexa. Because really with Seroquel, if you're using it as an antipsychotic, it really should be a higher dose. So the sleep doses are kind of lower. The high doses are more mood-stabilized or antipsychotic. So we usually would use like Zyprexa, for instance. You probably want to stay clear of Abilify too. So Abilify is used in, often in primary care, but Abilify is a partial agonist of dopamine. So some people get worse on Abilify or get more impulsive. So addiction plus Abilify usually doesn't work too well, but something like Zyprexa, Risperdal, Invega, those are all okay. Geodon's an option. There's some different ones, even Haldol, but I mean, again, like Dr. Zhang said, if somebody's bad, they really probably shouldn't just be coming in once a week. But you'll often see like someone in the DDU will get on Zyprexa for a while. They stay on it for a month, 2 months, 3 months until the psychotic symptoms go away. And that'll make you sleep too, Zyprexa. And a little bit less of a benzo type effect the way Seroquel does. So
yeah, last minute I want to just mention this. The treatment guideline for substance use problem is not to use any psychotropic medications unless you are pretty sure the patient has a separate psychiatric problem. So because addiction, we're talking about symptoms from active addiction is so complicated, and they're mainly psychiatric. So a lot of times we tend to load them with a lot of medications. So the bottom line is, yes, the guideline tells us, try not to use antidepressant, try not to use mood stabilizer, try not to use any other psychotropic medications unless you have evaluated the patient, to some extent you feel pretty comfortable. This is a separate disease I want to treat. We can talk about that. I think we should have more discussion on this. This is a very good topic. I personally have a lot of questions as well. Yeah.
Thank you so much. And Jennifer actually chatted in as well. Meth psychosis might be an interesting didactic in itself. So I'll definitely take note of that for future. Thank you for chatting that in, Jennifer. But all right, we're at 5 p.m. everyone. Thank you so much, Dr. Zhang, for that awesome didactic. Thank you all so much for joining us, and always with the great discussion and questions and comments. Our next session will be on February 8th, and Katie Chasson-Dance will be providing our didactic on stigma. So keep an eye out for that reminder. Katie, was there something?
I was just going to say thank you for reminding me. So
Absolutely. Yeah. No worries at all. And we'll see you guys next time. Thank you.
Thanks, guys.
Thank you.